have Trainer Loren here.
And Trainer David.
So today's topic that we're going to cover is the Medicare Basics 101 Part D and Part C. So let's just go ahead and get started, shall we? So Medicare Part D is also known as prescription drug coverage or the RX plan. Medicare programs have 4 parts. Now I know for a lot of you, you've already seen this, so I apologize in advance, but we do kind of need to go over it. So we have the Medicare Part A, coverage for the inpatient hospital care. We also have the Part B, which is the coverage for doctor services and outpatient hospital care. Part C, which is the privatized coverage that replaces Parts A and B. So basically, it's those private carriers that provide Medicare health plans. So like Blue Cross, Blue Shield, Humana,
Aetna.
Yeah. So these Medicare plans are also known as a Medicare Advantage plan. So the Part D, which is the privatized prescription drug coverage, allows Medicare beneficiaries to obtain prescription drug coverage from health carriers through a variety of plans. Newest part of Medicare program, which was inception of January 1, 2006.
And that was the last real change to Medicare, adding Part D.
Kind of sad when you think about it. So Medicare is coverage for people that are ages 65 and above, people that receive Social Security Disability Income, the SSDI, beginning in their 25th month, people with end-stage renal disease or ESRD, people in a few other scenarios like that Lou Gehrig's, also known as ALS. And then we have the Centers for Medicare and Medicaid. So these are the CMS services. So this is the government body that regulates the Medicare programs, beneficiaries, and the health carriers whom offer the various forms of Medicare health coverage. So please know that they also publish the CMS marketing guidelines. This is the fundamental document to ensure that Medicare beneficiaries are provided with accurate information.
There's a couple of different ways that you can get prescription drug coverage. You can get it through a Medicare Advantage prescription drug plan, an MAPD. That's going to combine Medicare Parts A and B with drug coverage Part D, or just a prescription drug plan, a standalone Part D plan, which would offer the prescription drug coverage only, no medical, and it's going to be paired with original Medicare, and that's going to be with Medicare Parts A and or B, or like it said earlier with the Medicare Advantage plan without prescription drug coverage, pretty less frequent for that. A couple of terms that we need to go over real quick so that we're all on the same page. There's the formulary. Now, the formulary is Medicare's fancy name for list of covered drugs. And you need to kind of know that the rules for formularies when they make these plans is that CMS is required that for every therapeutic category of drugs, there must be at least 2 listed. So there could be, 6, 10 different drugs that are used to treat a single specific ailment. Medicare requires that each formulary must have 2 to choose from. Now, what you're going to see really happen is that the premium, which comes up next year, in other words, your monthly payment will vary on how rich that formulary is. The one that only had the 2 would probably be a lot less expensive than the one that carried all 12. But the premium, PDP premiums vary from plan to plan based on how rich that formulary is. And that the Part D enrollees with higher incomes pay an income-related monthly adjustment amount. That's known as Part D IRMA. A deductible, just like in under 65, the amount that you have to pay as a beneficiary before the insurance company starts to pay. And then co-pays and co-insurance. Always think of co-pays as a dollar amount and a co-insurance as a percentage. Okay? Now these drugs will be in tiers. Your typical Part D plan will have 5 tiers, although 4 and 6 are not unheard of. And they typically run like this, where tier 1 and 2 are generic, with tier 1 being the preferred, tier 3 being name brand drugs. Tier 4 is kind of a catch-all, can be generic, can be name brand, but it's known as the non-preferred. So it's still covered in the formulary, but is not one of the preferred drugs that the company would want you to be using. And then tier 5, which are specialty drugs. And usually that's the latest and greatest and kinds of things that you see advertised on television and that kind of stuff. Sometimes you'll see tier 6, and that usually refers to how it's going to be handled in the coverage gap, and more on coverage gap coming up. Pharmacy networks, okay, preferred or standard. You can go to either one. Your lowest pricing will be at the preferred, and they usually kind of work in pairs. Like Aetna uses CVS, Humana tends to use Walmart, United tends to use Walgreens. I mean, they've all got their relationships built. There can be multiple pharmacies listed as preferred or standard, but your lowest cost will always be at the preferred pharmacy. Then mail order will also be an option through mail order pharmacies. Good note for that is that many of the generic drugs, those tier 1 and 2 drugs, in many of the prescription drug plans, there's a 0 copay for a 3-month supply on those tier 1 and tier 2s. So good thing to take a look at with customers that are on the low income side. Limits on drug coverage. These are some letters that you'll see when you look up your customers' drugs in the formulary, and they're the cost utilization measures. QL, quantity limits. Many of the opiates these days will have pretty low quantity limits, where maybe you can get maybe 7 or 10 at a time before you'll have to go back and refill it. Then PA is prior authorization. If you see that come up, just let your customer know. Don't wait till you've taken the last pill in the bottle before you go refill that. Some of those prior authorizations can take 24 to 48 hours to come back. And ST is step therapy, normally associated with high cost drugs, where there's multiple lower cost drugs available in the same therapeutic category. And the insurance company may require that the lesser the lesser cost drugs are tried first before they will jump in and cover that more expensive drug. And the coverage gap. Some plans offer lower copays while in the donut hole. More on that coming up here. What we're going to look at is what's called the standard plan. Now, these are the guidelines put out by Medicare. Medicare itself does not have a prescription drug plan. You have to go to a private carrier. But Medicare provides the standard benefit that each company, as a minimum, must meet. They can be better than the standard, but they must at least cover everything in the standard. It'll make more sense here in a moment, like the deductible. Medicare's deductible is $415. You could have a $0 deductible, but you could not make it a $500. That would not be better. That would be worse, right? Then the initial coverage limit, and this is Medicare and CMS will be tracking the true cost of the drug, not what's paid. In other words, you could have a copay of 25% on a $100 drug, meaning your share would be $25 copay, but they're going to be tracking that $100. So that's going to be your coverage, initial coverage limit of $3,820. When it reaches that, you're into the gap, known as the donut hole. The cost changes in the donut hole, where during the initial coverage limit, The standard model was 25% of the cost of the drug was borne by the individual. Once you're in that gap, it changes to 25% for name brand drugs, 37% for generic drugs. As they continue to track that true out-of-pocket cost, when it reaches $5,100, you're into what's called catastrophic coverage. And again, the cost share changes. And depending on a lot of different things as to where you fall in, are you receiving a subsidy, or are you using Medicare, Medicaid, just what's going on. For persons with nothing, in other words, most of us, your cost for the drug will be 5% of the cost, or $3.40 for a generic or preferred drug, whichever is greater, or 5% of the cost for, or $8.50 for all other drugs. So 5% and $3.40 for tiers 1, 2, and 3, 5% or $8.50 for tiers 4 and 5. And then if you're receiving any of the low income subsidies, you can be as low as $3.40 for generic and preferred, and $8.50 for all others. Notice that the 5% goes away. Kind of another way of looking at that same thing in stages. So stage 1 would be your deductible stage, where you're going to pay the full cost of the drug until your out-of-pocket reaches that, you know, your deductible of $415. Now you'll pay 25% for all your prescriptions until your total out-of-pocket, or true out-of-pocket, reaches $3,820, while in the gap, the cost structure changes to 25% for name brand drugs, 37% for generics, until the true out-of-pocket reaches $5,100. And now you're into the catastrophic coverage, where we're going to break that down a bit more, but it can be $3.40, $8.50, or 5% until the end of the year. So now, there is some help available out there.
Now, David, who keeps track of that donut and when it no longer applies?
Oh, that's a great question, Levin. CMS is the one that's actually tracking that. So CMS is tracking it, but the drug company is collecting it. So even if you move and change plans, CMS knows where you stand, and it will not, you can't move out of the gap or move into catastrophic coverage. It's going to stay no matter whether you change plans or not.
Okay, so as you were mentioning, the extra help, the low-income subsidy, also known as Medis, it could be a dual eligible. There's different ways that it's described. So let's get into a little more detail. So LIS is a federal program administered by the Social Security Administration, so the SSA, for Medicare consumers who have a limited income or resources. So automatic enrollment for Medicaid recipients, others must apply. So if you have an insured and you think they could potentially benefit from the low-income subsidy assistance, by all means, you would be the hero of the day, would you not, David?
You would, and my experience has been that most of the public has no knowledge of this at all.
Exactly, one of those well-kept secrets. So in the event you have someone that does qualify for LIS, it is going to assist with monthly premium or the yearly deductible, prescription co-insurance and co-payments. It could eliminate the Part D late enrollment penalty or provide coverage for the donut hole that you were just talking about, that coverage gap. Assistance to cover prescription drug low-income subsidy co-payments, full benefit dual eligible institutionalized or receiving home and community-based services, the AHCPS is a $0 copay. Now, David and I would like to point out, nothing is free. Correct, David?
That's correct. And in fact, you're prohibited from saying free in the Medicare guidelines.
So you have to say either a $0 copay or nothing at all. Do not tell your insured or potential insured that it's free to you. So again, we can't stress this enough. We have heard of agents getting in trouble because they kind of sort of forgot to mention that little part, right, David?
Yep.
So for full benefits on the dual eligibles with income less than or equal to 100% of the federal poverty level, a generic or preferred drugs could be up to $1.25 copay per prescription. And then $3.70 for other, again, up to per prescription. And then we have the above catastrophic limit, which is a $0 copay. And then we have the full benefits duals with income less than 100% of the federal poverty level or other full subsidy eligibility beneficiaries, $0 deductible. Generic and preferred drugs up to $3.35 per prescription. The other is up to $8.35 per prescription. Above the catastrophic limit is a $0 copay. Partial subsidy eligible beneficiaries have a deductible up to $83, and the coinsurance to the initial coverage limit is up to 15%. Generic above the catastrophic limit is up to $3.35 per prescription, and the other catastrophic limits is up to $8.35 per prescription. Part D IRMA, which is David had mentioned earlier, but this is the income related monthly adjustment amounts. So Medicare Part D beneficiaries with a higher income are basically going to pay a higher monthly premium for that prescription drug. But David, what were those two examples that you were saying IRMA could come back and be a prime example of this?
Here's the thing about the IRMA is it's not what you're making today. It's got a 2-year look back. So they're looking at your customer's tax return from 2 years ago. So 2 years ago, what were they making? They could have not retired yet. They could have had additional incomes. In a couple of examples that happened that I had seen, where one was a family where they had sold the house, downsized, all the kids were gone, and some of that profit wound up on their taxes, and it pushed them over the limit, even though they weren't making that kind of money to be, in the IRMA. Now they were back then, especially when that house sale pushed them over the limit. And the other one was somebody that had taken the early retirement, where the company offered the severance package, and they got basically bought out to retire early. All that money, again, wound up on their tax return. And in that 2-year look back, they wound up having to pay IRMA. Now, the good news in there is it does go away. So it will adjust to your current income if it's a lot lower. But it will take, time before the 2-year look back window is where they are today.
So enrollment periods. So I know, David, you've pointed this out before. I've pointed them out before. And some of you are like, really, again? Well, unfortunately, yes. We have to talk about them again. We have to put them in front of you. So we're just kind of beating this down your throat, if you will.
Well, I always said there's no horse too dead to beat. So
good point. Good point. So we have the ICEP, which is the initial coverage enrollment period. So this is for the 7-month period. So it's the 3 months before the month of eligibility, which is the birth month, and then 3 months after the first month of eligibility. And then we have the AEP, the annual election period, October the 15th through December the 7th. This is where people are joining, switching, or dropping their Advantage plans or a PDP plan. Now, if you work it right, this could be the last plan that a member enrolls in. Now, keep in mind, that October 15 through December 7, any and all business that you write under the AEP is going to be effective January 1. So then we have the special election periods. So these are the situations outside of the ICEP or the AEP in which certain Medicare beneficiaries can enroll in a medical advantage or a Part D plan, such as persons moving out of the planned service area, losing employer group health coverage, low-income subsidies or Medicaid eligibility, whether they're new to obtaining it or they've lost it. And then, of course, those special need plans eligibility. So let's talk about the Part D penalty, David.
Okay, there's a late enrollment penalty if you don't enroll on Part D when you're initially eligible. Okay. The way that they word that, it says equal to 1% of the national average for Part D premiums for every month he or she delayed enrollment, and remains in effect as long as the enrollee has a Medicare Part D plan. So that means that once this penalty starts, or once it has happened to the customer because they were late enrolling, it never goes away. They'll pay that penalty for the rest of the time. With one little exception is if they do get that low income subsidy, they'll cover it for them.
So it is waived.
It can be waived for the low income. But the way that they do it is there's a national benchmark, and we're looking at 2017. It was $35.63 was the average of all the plans out there. So that works out to be about a 36 cents per month penalty. And it's every month. So if you only go a year or two, we calculated it out at 2 years. If the individual didn't enroll, it's going to be $8.64 for the rest of the time that they would be enrolled in a Part D plan. Now that was just 2 years. Imagine if they go 10 or 20 years without enrolling in a Part D. It'll make it just prohibitively expensive. So don't let that happen to your customers. I used to always insist that if they're considering not getting a Part D simply because that they don't take any prescriptions, try to convince them that they should go with the least expensive plan available in the area. And some of those are down in the $12 or $15 a month range. So just don't let that happen to your customer. All right, so let's take a look at Part C now.
So the Medicare Part C Advantage plans, like your HMOs, your PPOs, your POSs, point of service, include the Medicare Part A, Part B, and sometimes can be Part D. So Medicare Advantage plans.
Well, sometimes they call them Part C. That's one of the things that makes Medicare so much fun, is that there are so many names for the same thing in Medicare. Although some of them do have some very exact meanings. So you do that, and we need to be the ones that really know these, because I can assure you our customers do not. Now, a Medicare Advantage plan, sometimes called Part C, or sometimes just referred to as MA or MAPD, these are going to be offered by a private company and approved by Medicare. So if a client joins a Medicare Advantage plan, they still have Medicare. This is always a point of confusion. The thing is they now get their Medicare Part A, the hospital, and Part B, the medical coverage, from the Medicare Advantage plan. So that would be from like Aetna or Humana or United, but it's not coming from original Medicare. Okay? So I like to just kind of contrast that. They're still on Medicare and they have Medicare. It's just that it's they're getting all of their care through the plan, not the government. So there's some options. First of all, they have to be approved by Medicare, and they're going to be run by private companies, are part of the Medicare program. Sometimes you'll hear them referred to as Part C. They're available based on the county that you live in, right down to the zip code. And provide all of Medicare covered benefits, and many of these pick up some extras in there. Most common will be the dental and vision. Sometimes they're not required, they're just required to cover everything that A and B covers. But you'll see that they'll come in and pick up a few additional things. So let's kind of look at the different ones that they have. This is going to be very similar to the under 65, an HMO. And here's kind of the key things that go with the HMO. You must get care from your primary care doctor, your specialist, and hospitals that are in the plan's network. Okay, and if you go outside of the network, you know what happens?
Higher copays?
They pay nothing in an HMO. So that's a key thing. Now, if you have an emergency or urgent care scenario, they'll cover that, just like under 65. But in Medicare, if you're in an HMO, you must do a couple of things. One is select your primary care doctor and see that doctor first before you see the specialist. Now, the PPO plan. In this scenario, you're going to pay less if you use a primary care doctor, specialist that are hospitals that are in the plan's network. But you do have the ability to go out of network. Okay, but if you go out of the network, your coverage will cost you a little more. You'll see a higher copay and higher co-insurance in a PPO for out of network than in network. Now, Medicare does have what they call special needs plans, and they can be very varied. There's quite a few different ones, but they're coverage for specific groups of people, such as those in an institution, you know, like a nursing home or something like that. Those who have dual eligibility, like Medicare and Medicaid. And then there's some for what they call those with chronic conditions. And by chronic conditions, things like, you know, congestive heart failure or COPD.
Diabetes. Yeah. The list goes on and on.
Right, but in those cases, you have to be a member of that group in order to be able to get that special needs plan. Now, one of the features of special needs plan is that they always include drug coverage. And then there's these one called, well, Medicare itself is a fee-for-service plan. You can get an Advantage plan that is called the private fee-for-service plan. And this allows the beneficiary to go to any primary care doctor, specialist, or hospital that accepts Medicare and accepts the terms and conditions of the health plan for each visit. So you'll see these in areas that are typically, you know, maybe out in the country where there's just wasn't enough doctors to build a network of doctors for an HMO or a PPO plan. And so you can go and see any doctor you want, but then the health plan will contract with the doctor for that visit.
5-star rating. So a 5-star rating is based on preventative and chronic care, the member satisfaction, the service measures, the access and care measures. So 5-star rating allows year-round enrollment, but understand this is only a one time per year that you can elect to use this. So it's for those low performing star ratings for that special election period. Please refer to the 2017 Medicare NU publication for more information.
I'd say that if you have any 5 stars in your area, that would be something that you would want to know, because that'll give you an SEP for most people, unless they've already used it once. But for most people, it'll give them that SEP when they are calling in and looking for Medicare.
So word of caution, members in an HMO and a PPO, Medical Advantage only, plans cannot sign up for a freestanding separate Part D plan to go with their MA plan. So the PFFS, which is the Medical Advantage plans, can pair with the freestanding PDP plan. So, special election periods. This is a situation outside of the ICEP or the AEP in which certain Medicare beneficiaries can enroll in a medical advantage or a prescription drug plan. So, person moved back into the US after living outside the country for a little while, moved back or out of an institution. So like that care facility David was talking about, released from jail. Now, please note, this is not county jail. This is prison. Correct, David?
Correct.
And then we have the eligible for Medicaid, or the persons that are no longer eligible for Medicaid. Medicare ends the plan that the person was in, or they qualify for that extra help. Remember that low-income subsidy? So again, the star rating, we just kind of pointed out. Medicare Advantage plans sometimes are also called Part C, right, David?
They are. And I always looked out for the one who says, and I've had customers tell me, oh yeah, I've got a Medicare supplement. It's an HMO.
Well, wait, that's not an HMO for a supplement.
Right. That's why I was saying, so we got to be careful with this, this alphabet soup that a lot of Medicare comes up with and people come up with, to know that a Medicare Advantage and Medicare Part C are one type of plan and a Medicare supplement is something different. We have to know the difference because believe me, our customers will mix them up. So Part C, or the Medicare Advantage, is offered by a private company and approved by Medicare.
Okay.
Okay. It may or may not include prescription drug coverage, which we went over. If it's the HMO or PPO, you can get it with and without. If it's a fee for service, was the one exception that let me get a standalone if it came without it. And the other key thing that all these plans must offer, and this is part of being that contracted with Medicare, we had talked earlier that Medicare itself doesn't have an out-of-pocket maximum. These plans must provide one. Okay, so that's a protection for our customer. And you'd have to look at the benefits of that particular plan because they can vary. I've seen them on the low end from $2,500, on the high end up at $10,000. So you have to look at the schedule of benefits to determine exactly what the out-of-pocket limit is. And as we had said earlier, many of these MA plans will also provide additional benefits not covered by original Medicare.
So Medicare Advantage Part C, so you'll note that it says Part A, which is the hospital insurance, Part B, which is the medical insurance. So a Medicare Advantage plan must cover all of the services that original Medicare covers. Beneficiaries must live in the Medical Advantage or the Medical Advantage prescription drug plan area of service. Pay an MA or MAPD plan premium. Now again, there's always the exception if they are those LIS personnel. Part C will help cover costs like deductible, co-pays, co-insurance, most drugs, preventative services, dental and vision sometimes.
They're not required to include it because it's not covered by Medicare.
Correct. Things that it doesn't cover. So Medicare is not going to cover that long-term care facility. Most dental care, well, I found that it's pretty much those dental implants that people really want right now. Nope, not covered. And then we have the eye examination related to prescription glasses, whether that's eyeglasses, contacts, or even sunglasses. Dentures, not a covered benefit. Cosmetic surgery, acupuncture, hearing aids or those exams for fitting them, or even routine foot care. David, don't you think that this is another area where an agent could sell some extra product?
I see it too. Remember, in Medicare, you can add other health products with that. You simply can't go outside of the health industry when you're dealing with the customer. And we wanted to touch base on these that are not so commonly used. You'll see that even though we covered the fee-for-service plan, where the member can go to any provider that accepts the plan's terms, and they may get those extra benefits, but a private company decides how much it will pay and how much the member will pay for the service. And the key thing there is that the doctor or the hospital also had to agree on each visit whether or not they would accept the plan. Not a common plan. Usually think of rural areas where there were no real HMO PPO networks. And then the Medicare Savings Account plan. It's two parts. One part is a Medicare Advantage plan with a high deductible, and then a Medicare Savings Account into which Medicare deposits money that people can use to pay for their health costs. The other thing about those Medicare savings accounts, no drug coverage. You have to get a separate standalone plan for that. But neither of those are very common plans, but they are out there. So a little bit of an understanding between traditional or original Medicare and a Medicare Advantage. So when you're looking at helping a customer with the plan, you need to understand how that specific Advantage plan works that you're considering with any current coverage they may have. Because if they have a retiree or group health plan, and ones that are really look out for are those union plans. If they enroll in an MAPD plan, they can lose that coverage. And once it's gone, they can't get back into it. So be careful with those. Compare coverage and cost available through traditional Medicare programs combined with a Medigap policy and a prescription drug plan versus the MAPD plan, which would include, monthly premiums, deductibles, co-payments, and yearly out-of-pocket maximum. Because remember, in that Medigap plan, their only liability is going to be maybe the Part B deductible and the monthly plan premium. Because everything that Medicare covers, that plan will cover, and so you don't even have to worry about out-of-pocket maximums. Inquire as to whether or not they're required to receive service from medical providers. So this one and the last one, to be sure that the physicians and healthcare providers they like to want to use are in the network. You have to look up the doctors and the hospitals and the specialists because they're all built around these networks, and you want to make sure that the doctor your customer wants to see is part of that plan. The last thing that you want to hear is, you sold me a plan and my doctor's not in the network, because that will definitely get you in trouble. Now, you got to read that plan literature and see what kind of plan it is and what it pays for. This is not all MA plans, even if they're the same type from the same insurer, work the same. You'll see that each MAPD company, like Humana or Aetna, will have multiple HMOs and multiple PPOs, and each one of those will have a different cost structure. It could even have a different network and a different maximum out-of-pocket. There are plans that do not include prescription drug coverage. I'm always asked, who would buy just an MA plan?
Well, our prior servicemen and ladies actually can opt out. They normally get their drugs through the VA.
So yeah, for them, sometimes it's just the ability to see, a civilian doctor and pick up some of those extra benefits that some of the MA plans offer is the attraction there. So they don't want drug coverage. They've already got it.
Right.
And then what are some of the additional things that you can get? Okay, determine, what plans at what additional costs, because all the preventative services and extra benefits should be identified, as well as any limitations associated with the visits or service. And You need to determine, where they can go for regular and non-urgent care, because in these plans, we all know, just like in under 65 plans, emergency and urgent care is always covered. It's what happens when they want to just go to the doctor and they're out of town. Okay. And then you want to make sure, again, that the physician is actually a member of the plan's network. This is just another way of kind of looking at it, what original Medicare does and what the advantage of an Advantage plan is. And you're going to see that in a couple of areas, the Advantage plan is going to help out the most. Okay, cost, you still have to have your A and B. So original Medicare, there are many Advantage plans where your only responsibility will be the premium. And many of those are zero copay premiums. And then you'll have copays when you go to the doctor. It replaces that 20% coinsurance. You can get a supplemental insurance, but whether or not you can get into that, it depends upon where you live and where you are in the cycle. And if you can't buy a Medigap policy to help pay your out-of-pocket expenses in a Medicare Advantage plan, a lot of times you get that question. Can I get a Medicare Advantage and then use a supplement to pay for the copays? No. Extra services. Okay. Original Medicare just does the A and B. Many of the Advantage plans will throw in a lot of other things, routine visions, hearing, dental, that you can have picked up. I've seen them pick up quite a few other things, over the counters, transportation, gym memberships. They won't all have everything, but I've seen a combination of a lot of different services tucked into those Medicare Advantage plans. The big advantage of original Medicare is I can go to any doctor I want and anywhere in the country as long as they accept Medicare. With the Medicare Advantage plan, I have to stay inside my network. So I can be in an HMO or a PPO plan, and even if I'm in a fee-for-service, the doctor has to accept what they're willing to pay. Again, with original Medicare, don't need a referral, but if I'm in an HMO, I do. Okay, and drugs, well, original Medicare, you have to get a separate Part D. Most of your MA plans will have that Part D included. It would be kind of a choice to not have it included more than anything else. And I think here is the most significant reason for getting any plan, whether it's a Medigap plan or a Medicare Advantage plan, the out-of-pocket limit on Medicare. There is none. You will pay until the cows come home, and then you will continue to pay even after the cows come home. Where at least with a Medicare Advantage plan, there is a worst case scenario of what the maximum cost for you will be. So gosh, Loren, that was quite a bit here today.
It was, but remember, if you guys have any questions at any time, make sure that you email the training box, and David and I would be more than happy to take the time and help you out with those questions.
Sometimes kind of we could help out with a lot of that back office stuff. Is it a SEP? Does it qualify? Need a little help? We would be glad to answer those questions and let you do what you do best.
Right, which is the selling. So again, guys, if you have questions, email the training box, and David and I are always here if you have those situations where you're not comfortable, whether it's the right policy for your insured, just reach out, and we're more than happy to help. So thank you on behalf of David and myself. We would like to say thank you again for spending some of your day with us. So we're going to sign out for now, and we'll see you. Bye, guys. Have a good day.